We come to the last but not least speaker in this block, and that is Michael Moore, sitting here. He's Professor of Primary Healthcare Research within Medicine at the University of Southampton, and lastly, a real doctor, a general practitioner, with more than 25 years' experience in a practice named Three Swans. What a nice name. And this surgery is in Salisbury. Everybody knows where Salisbury is. Of course, it's in Rhodesia, which is today called Zimbabwe, and a country which is almost completely destroyed by a 39-year-old dictator. But the Salisbury where Michael works is not there. This is in England, and it's a contemplative cathedral city of 42,000 inhabitants in Wiltshire. Well known among Michael's publications is an RCT about the effectiveness of steam inhalation and nasal irrigation for chronic or recurrent sinus symptoms, published in 2016 in the Canadian Medical Association Journal. Today, he will talk about an equally important subject, the optimal management of acute sore throat, current best evidence. Michael, please.
So thank you very much for inviting me to speak to you today. I'm going to be talking in a slightly different approach, because I'm going to be talking about a number of studies rather than a single study, and some work that we've been doing in Southampton and with colleagues in the UK mainly, looking at the management of acute sore throat in primary care. And so I'm going to just talk about why does it matter, why are we interested about prescribing. In fact, one of our colleagues in the audience already asked a very good question. Okay, I'll get a bit closer. A very good question, which is, why are we prescribing it at all? And I will just deal with the evidence around that in a moment. And then I'm going to be talking about potential alternative strategies to deal with acute sore throat in the community. And so, as you've heard, I live in Salisbury, and this is where I take my dog for a walk in the morning. This is the view from Harnham Slope, which is just down from where I live, and the practice that I've been working in for just under 30 years is the other side of the cathedral, around about a kilometre or so from where I'm standing when I took that picture. So why does GP prescribing matter? We've heard a little bit about this earlier this afternoon, but in the UK at least, 80% of antibiotics used in humans come from the pen of the general practitioner, the family doctor. And in fact, people often complain, they say, well, if you ask GPs, they say, I know all about antibiotic resistance, but it's not my problem, it's the hospitals or it's the agricultural industry. In fact, 80% of antibiotics in humans come from GPs, and around half of antibiotics by weight are used in humans in the UK. In other countries, then animal use is greater than that. There's an association between high use and high resistance. So this is the correlation between penicillin use and the prevalence of penicillin-resistant strep pneumoniae. I'm happy to get closer. Oh, that may be better. Okay, can you hear me better now? I won't go back. So this is data from Herman Goossens, and showing that if you're in a high prescribing country, there's a very high chance of having resistant organisms isolated. If you look at the bottom left-hand side, there's the Netherlands, very low prescribers, Germany, the UK. So much lower risk of antibiotic resistance with low prescribing. So this is outpatient prescribing, so this is prescribing by GPs. This is our prescribing clearly influencing antibiotic resistance. And if you're exposed to antibiotics, then you have a greater individual risk of carrying a resistant organism, and that after a single course can last for around about, it gives you, doubles the risk for 12 months. And just to give you the context of European antibiotic prescribing, there's England, we're the one with the black arrow. Germany has a little bit lower antibiotic prescribing. At the moment, the UK prescribe on per head double the antibiotics prescribed in the Netherlands and Sweden. And we all feel quite safe going on holiday to the Netherlands and Sweden. We don't think we're going to die from infectious diseases when we go there. So I think that there's plenty of room to further reduce antibiotic prescribing, certainly in the UK. And this is UK data again from a number of practices, 500 practices. We're very privileged in the UK because the computerized records which every GP keep can be extracted, anonymized and analyzed, which enables us to find out much information about prescribing. And so you can see here that half of people with cough and bronchitis receive an antibiotic prescription, and 60% of those attending with a sore throat. There's variation even between practices in the proportion of people receiving an antibiotic, from 40% to nearly 70%. And again, if you think about patients of those practices, they're not at great risk of anything terrible happening. So why prescribe for acute sore throat? And so I've got 3 things just to deal with briefly: patient pressure, relief of symptoms, and concerns about serious complications. So patient demand, then there is some pressure on us to prescribe antibiotics, and 40% of people who see their GP go because they're wanting to get an antibiotic, but actually a lot of people go because they want a diagnosis, they want to be reassured. And I think now with the rise of antibiotic resistance and the mass of publicity around the risk of antibiotic resistance, that the door is much more open to discussions about non-prescription than it was maybe 10 years ago. So the first thing we can do is ask the question, why are you here? And do you really think you need an antibiotic? This is a handy table from the NICE guidance, and just to point out the average benefit from antibiotics in a series of respiratory infections, otitis media, sore throat, sinusitis and bronchitis. You can see the circle there is around the expected benefit following an antibiotic prescription, which for all those illnesses, which vary in duration from a few days to around 3 weeks, is only around half a day to a day. So the effect of antibiotics is pretty miserable, and that answers the question earlier, why are we prescribing? It certainly isn't because we expect our patients to get better quicker when we give them a prescription. And just to highlight the sore throat, this is the patients normally wait around 3 days before they see the doctor. They're ill for another 5 to 7 days after they've seen the doctor. They're ill for 8 to 10 days in total, and so you impact on their illness by 12 to 24 hours with an antibiotic prescription. There are other things that happen when you prescribe, though. This is data which goes back now nearly 20 years. This is the very first trial that we did in Southampton, looking at 3 alternative strategies for treating sore throat. One was to give everybody an antibiotic prescription. One was to give nobody an antibiotic prescription. And then the middle course, which we have been calling delayed prescribing, but you might equally call just in case or emergency prescription, which is when you negotiate with the patient and you say, well, I've examined you today. I don't think that you need an antibiotic, but you might think you need an antibiotic. So why don't we wait and see what happens? Because I know that most patients will get better over the next 4 or 5 days, and I know that very few patients will respond to an antibiotic. So why don't you take this prescription away and see if I'm right and see if you're getting better. But if you are getting worse or you're getting sicker, then you can take this prescription. And we know that around about 40% of people will end up taking the prescription, so 60% don't. So there in that first column is the number of people getting better, the proportion recovering. So really no difference between the antibiotic strategy. Everybody was pretty happy with their doctor and what they did. But what you do with that dark blue column there is to promote a belief in antibiotics and also an intention to consult again in the future the next time the patient gets a sore throat. So antibiotics don't do anything for symptoms, but they do promote patients' beliefs and intention to consult in the future. And just to show you this in another way, this is the recovery curves for each of those three antibiotic strategies, and I think you can convince yourselves that there is no difference between the rate of recovery whether you give an antibiotic or no antibiotic or a delayed prescription. So, okay, I'm not prescribing because I'm going to get people better quicker, so it must be that I'm worried about serious infections. What other infections? So cellulitis, otitis media, and the most serious sequelae of acute sore throat is a peritonsillar abscess. We would call that a quinsy in the UK, but that term I don't think may be understood. So a peritonsillar abscess. And it's very difficult to know if antibiotics are helpful because the randomized controlled trials are relatively small, and these complications are actually really rather rare. So you can't really tell whether antibiotics are preventing things from happening. And so we take a different approach, which is to look at a prospective cohort study. So we looked at lots and lots of patients attending their family doctors, and in fact we recruited just under 14,000 adults presenting with acute sore throat to their doctor, and then we collected detailed information at baseline, and we looked to see what happened to them over the next month, to see how many of them came back with serious illness. And in fact, very few people, only 1%, came back at all with any kind of infective complication. And the risk of that serious complication, peritonsillar abscess, only 3 in 1,000. So very low risk of serious outcomes. We also looked to say, well, can we predict? It would be really, really smart and neat if you could say, well, I know, out of all those patients that come and see me, this 5% are the ones who are at risk of peritonsillar abscess. But actually, we weren't really able to do that using baseline symptoms. There were a couple of symptoms that did predict peritonsillar abscess, but the odds ratios were only 2, so with a very rare outcome, that doesn't help you as a clinician. So we also looked at symptom scores. I'm going to talk a little bit about fever pain. Centaur you may be familiar with, which is an existing score which helps you predict patients at higher risk of having streptococcus on their throat swab. But unfortunately, the peritonsillar abscesses were just as likely to occur in people with low scores. We looked also at the effect of antibiotics and whether that reduced the risk of those serious complications and infective complications, and they did by around about 1/3. But interestingly, the patients given the delayed prescriptions in this group also reduced their risk of infective complications. So although as a family doctor we can't predict who's going to do badly, if you give the patients the power, if you say, well, I don't think you need this prescription today, I'm not going to make your symptoms any better, but if you take this away and something, you're not feeling comfortable about things, then the right patients seem to end up taking antibiotics because they have an equally effective reduction in suppurative complications. So just to kind of summarize there, if you 1 in 10 people reconsult after they've seen their family doctor with a sore throat. 1 in 100 approximately have an infective complication of some kind, and only 1 in 1,000, I've rounded these for make them easy to remember, a significant complication. It's not possible to identify those at risk based on their symptoms and examination at baseline. So there's another way of looking at this, which is to say, well, let's look at the global prescribing and see what happens with low and high prescribing practices. And we were able to do that again using this anonymized, aggregated database. And there is no association between the risk of mastoiditis, empyema, meningitis, and intracranial abscess with lower prescribing. But we did show an association between lower prescribing practices and the risk of pneumonia and peritonsillar abscess. So you might think, and I suppose that's consistent with the observational data, that if you reduce your prescribing or if you're a low prescriber, you're going to have a few more complications. But what does that mean in reality? Well, in the UK, the average list, that's the registered patients with a practice, is around about 7,000. So if you look after 7,000 patients and reduce your antibiotic prescribing by 10%, those practices might see 1 new case of pneumonia each year and 1 additional peritonsillar abscess every 10 years. And those, of course, are treatable, but it's not without risks reducing prescribing, but the absolute risks are low because these events are rare. So then I'm going to move away now from that observational data and talk about a trial, and I'm going to be talking about alternative approaches in practice and what we think at the moment is the best way of approaching this. And so there are different things. We're interested in all these things which I've listed on this slide. So targeting antibiotics, using near-patient tests, which Mark talked about earlier, using clinical scores, identifying high-risk groups. And we're also very interested in alternative treatments, and in particular herbal treatments, and we're doing some trials with herbal treatments, and also communication skills. Improving communication skills is a potential way forward. But today I'm just going to touch on one trial of near-patient tests and clinical scores. So you may be familiar with the Centaur Criteria. This has been around for 15 or 20 years. It was developed in a secondary care setting in an emergency department, and it was used to predict the presence of strep A on the sore throat, on the throat swab. So this is quite widely used to target antibiotics. So people with a Centaur score of 3 or above are often offered an antibiotic. But we were concerned about, well, is strep A the only pathogen which is relevant in acute sore throat? And there is some evidence that strep C and G are also important. So here is some data, observational data collected and looking at symptom clusters, and the Group A is the dark blue and the C and G are the light blue, and you can see that they cluster together in terms of the symptoms that people experience, whereas the very light blue appears to be different, so the other strep types. So we think A, C and G are probably important. In the UK, C and G are isolated in around 20% of throat swabs. So if you're using a strep A near-patient test, you miss them. You miss 20% of the potential pathogens. So we developed a new score called fever pain. These are the items on the score. It's more difficult to use than Centaur because there are more items, so I acknowledge that. Some of the items are common, though, to Centaur. So fever in the last 24 hours, presence of pus on the tonsils, people attending rapidly, and that's slightly difficult because that means that people can get access to their doctor for an appointment within 3 days, and clearly supply issues might change that. Severely inflamed tonsils, so that's a judgment by the examining physician, and the absence of cough or cold. And we wanted to, I've got some data just to show you how these perform in an observational data set. So this is the Centaur criteria, presence of pus, cervical nodes, fever, and absence of cough. And you can see the circles there. So the low scores, the people who you wouldn't treat probably, you can see that's a very small proportion, and the high scores, 3 or 4, in this data set, which was derived in primary care, not an emergency department, you can see that those two figures adding up to around 40% of people probably qualifying for antibiotics. If you use the fever pain score, then you can see you've got a larger proportion with low scores, a lower proportion with the high scores in whom you would use treatment, and some intermediate scores there where you might use a delayed prescription. So we did a randomized trial, and we compared what we thought at the time was the gold standard treatment, which was a delayed prescription. I showed you that data earlier, showing that using a just-in-case or emergency prescription was just as effective in terms of symptom relief as an immediate prescription. So the control group for this trial was a just-in-case or delayed prescription, and there were 2 comparator groups. And one of them was the use of that clinical score, the fever pain score, and the other comparator group was using the fever pain score to rationally target the use of the near-patient test, the strep A test, in the intermediate scores. So low scores got no antibiotics, high scores got an antibiotic, and intermediate scores got a test, and only if the test was positive did you get an antibiotic. And so we showed actually using the clinical score and also the clinical score plus the near-patient test did reduce antibiotic prescribing further by around about a third. So these are the results there showing that the fever pain intervention reduced the symptom severity and the duration of symptoms and antibiotic use. Near-patient tests with the fever pain score did almost as well, but not quite as well. So I'm just going to wrap up now. So what's my conclusion? So targeting antibiotics using a clinical score improves symptoms and reduces antibiotic use for acute sore throat. The use of that with rapid antigen tests provides similar benefits, but there was no great advantage over using the clinical score alone. Now you might hypothesize, well, I've already told you that the near-patient test is very specific for strep A, and it may be that if you had a strep A, C and G test, it might perform better, but the strep A test certainly didn't add value to the clinical score alone. So outcomes are similar using immediate or delayed prescribing. Short-term reconsultation is higher with no prescribing, and immediate prescribing encourages belief in antibiotics for future consultation. Complications are rare and hard to predict. Delayed antibiotics are probably as effective as immediate antibiotics to prevent complications, and A, C, and G are all important pathogens, we think. Fever pain better predicts A, C, and G, and also in clinical practice in a randomized trial resulted in improved symptom control and lower antibiotic use. So at the moment, where are we? We think probably the optimal strategy is to use the fever pain score, targeting prescribing. But if you don't want to do that, you don't have to. You could use a just-in-case prescribing. I think that works pretty well, and it certainly results in much lower uptake of antibiotics and probably helps to prevent infective complications. So maybe you use the score in those more severe cases where you're a bit more uncertain. It's hard to remember. There is a website, but of course it's not in German. It's in English. I logged on yesterday to get the web address, and that's the correct web address. And since this has been posted there about 4 years ago, I checked yesterday, there have been 999,000 users of that site. So just under 1 million people have logged on and used that site. I don't know if they've all used the score, but it certainly implies that it's in current use. It's now in the UK guidance from Public Health England, recommend the use of the fever pain score. It would not be difficult to create a simple online tool in German, which you could log on to. This one, you log on, there are radio buttons, and then it produces a history summary which you can cut and paste into your clinical record. So it's quite quick to use and does enable you to target antibiotics. And so I'm going to stop there. So shall I stay here for questions, because I think Michael was going to lead questions. Yeah.
So just in case there are open questions, please come up and ask for all the lectures, not only for Michael's, but I don't see any hands. Are there? Okay. Jean?
When you were comparing fever pain versus fever pain plus rapid diagnosis, was the intermediate risk group in the fever pain only group getting a delayed prescription? Yes. So it was really delayed fever pain plus delayed prescribing versus fever pain plus rapid test informed prescribing? Okay, great.
Maybe I didn't pay enough attention, I didn't understand, but it seems to me the best thing would be, as Dr. Abel said, to combine the score and then only test people with an intermediate or high score to reduce further antibiotic prescribing. Is that what you said?
That's what we did.
Okay.
So the third arm. Okay, now we have two. The third arm there was using the score And people with a low score got no prescription, people with a high score got a prescription, and people with an intermediate score got a test. The patients loved the test. They thought it was fabulous. You know, the doctor said you need a test, and taking a throat swab and I'm putting it in. Look, and it's changing colour. It's like a pregnancy test. So the patients love it. Okay, they thought it was fantastic, and if the test was negative, boy, they were happy. I'm out of here. I don't need a prescription. And the doctor did a clever test. So very, very popular, the test. In the other arm, it was using the score, and the low score got no prescription, the high score got a prescription, and the intermediate score got a just-in-case or emergency prescription. So that was the comparison. And then the control group, everybody got a just-in-case prescription.
Okay. We currently recommend testing those with a high score because we believe that even those with a high score, but we're using the Centaur score, not your score, 50% don't have strep throat. So kind of to reduce antibiotic, and we don't care so much about the intermediates because we still believe, well, given the rarity of infections, we don't care so much about them. So I would, my gut feeling is I would rather recommend testing high score and not testing low and intermediate score.
If you're using Centaur, that's quite a rational strategy, because in the primary care population, the high Centaur scores were not that, they didn't have a very good positive predictive value. So actually there is about half of them were not going to have strep in the throat. Okay. If you use the fever pain score, then the higher scores there's a much higher probability of having strep in the throat. And so, you know, you could argue then for the very high scores with fever pain not to do a test, just to treat. I mean, so what you're suggesting is quite rational if you use the Centaur score because it doesn't perform that well in primary care.
You would recommend that we use your score, right? So we should switch from Centaur and start using fever pain.
I think probably, I mean, it's difficult. This was a score derived in the UK, but I suspect the populations and the people presenting in Germany would be similar, so I think it probably... Sorry? Yeah, well, I think what I heard today was that everybody comes in on day one to get a sick note. So maybe, I mean, that's a problem because if you then use fever pain, you'll get a point for coming in within the first 3 days. So I think you have to be quite careful then.
The last question was already, Günther just issued the question of application of the test, because in Germany you need a sick note, or often need a sick note from the first day on. And one of the items in the fever and pain was the patients came earlier than, I think, 3 days. And I think the majority of patients in Germany will come rather earlier compared to people in your country.
Yep, so I accept that is, I learned about that this morning, and I think that's a problem because the attending rapidly reflects the supply issues in the UK. It's very difficult to get an appointment with your doctor with a sore throat. Almost all the practices now, everybody who wants to be seen today, they have to phone up and they'll talk to the doctor. The doctor will say, we don't give most people with sore throats antibiotics. I'm not sure why you want to see me. So there's quite a difficult access problem. So, you know, in the study, in the data set that we used, then that was predictive of the presence of streptococci. It may not be in Germany.
Yes, thank you. Well, I'm from northern Germany, and we made an RCT just to try to implement our German guideline. And I can assure you that in Germany, patients too mainly come on day 3. It was the main first appointment when they came to the office. And then on the other hand, I just have another question. I was very astonished to see that you put such an emphasis on Streptococci C and G. Have you got any data on the time course of an infection by those streptococci?
We've got limited data about that because we've got that cross-sectional data where we've got the symptom cluster appeared to be similar for C and G. I mean, strep A obviously was the big one for rheumatic fever, so the risks, the nephritis. But in terms of symptom burden, it looks as if strep, C and G carry at least a similar symptom burden.
Yes, I only found data about the first presentation, so I was a bit astonished. In my experience as a GP, I always had the impression that those infections took longer and that the effect of antibiotics was hard to see. And so I don't know any RCTs about the effect of antibiotics in those infections by C and G streptococci. Do you know any data?
No, I don't. No.
May I put another question, or is that too much? Yes, it's just I ask myself how many strep tests were really made in this in your study, in your PRISM study. I admired your GPs who had such a schedule of 3 different strategies for patients with a sore throat, for they were randomized individually.
Yes, so
so if I think of my office to choose what strategy to follow, and then making this rapid test, and were they obliged? Do you really know how many doctors did that test?
I can't remember off the top of my head, but the way it worked is that you'd open an envelope and it would give you structured advice to work through the strategy that you are allocated to. We've done a number of trials on that basis, and GPs have responded quite well. So all our delayed prescribing, just-in-case prescribing trials have been done at the individual patient level. So the GP does not know what the patient is going to get until they open the envelope, and then they work through a structured advice sheet, and they'll say, you know, I think you need an antibiotic, and they will endorse whatever advice they were giving. So if it was an immediate antibiotic, they say, you need an antibiotic, here it is. And if there's a no antibiotic, you don't need an antibiotic, goodbye. And for the delayed prescription, there was a structured set of advice, which was antibiotics don't help for most people. These illnesses last around about a week. These are the things that you can take to relieve your symptoms. This is when if you want to use the prescription, then it should be, you're getting worse, that kind of thing. So there's some structured advice for the delayed prescription that the GP followed, like a script. So that's the way it worked.
Okay, maybe it's...
Yeah, Eva Homers here from Göttingen. One additional question to your, structured scripts. I presume you do need an individually informed consent by the patients to be included into this trial, do you?
Yes. All of these trials, the patient signs a consent form, and the information sheet will be saying we're looking at different ways of managing sore throat symptoms. But every patient will be consenting to participation. Yeah.
Ildiko Gadior, I just want to ask, I think it is a comment on your remark about the risk of contamination if we would use a point-of-care test in a practice and we would randomize on a patient level. I would say the risk of a contamination would be high, that the tendency that a GP would use this test in other patients as well would be quite high. But perhaps it's not in UK, they are disciplined.
I think that the GPs were quite well behaved, and also it's a very time-pressured environment, and it took a little bit longer to do the test, and so you probably were quite relieved when you didn't have to do a test. And it was only a small proportion, of course, because people with low scores and high scores didn't get any test. It was only the intermediate scores. So in reality, it was relatively few tests that were done. But we've done a similar trial with the CRP testing, where we randomized individuals to practices to whether they used the CRP test or not.
Just had a comment. I think it's really interesting to think about the system impact of the health system impact of how quickly people attend. In Germany, there are different pressures in terms of getting a sick certificate. In the UK, there may be access issues. In the US, there certainly are. We added a question to our current influenza trial of how long did it take you to feel as bad as you feel right now? 0 to 1 days, 2 to 3 days, 4 or more days, to try to get at, because really what we're trying to get at is how quickly did they feel this bad. So I don't know the data yet, but it'll be interesting. That may be a way to get around this access issue.
Yeah. We're also very interested in what happens after the consultation. So up till now, we've analysed the data on the day that people came and said, on the day you come, can we predict what's going to happen in the future? And, well, we're not very good at doing that. But the patients somehow end up taking the right people take the antibiotics, so there must be something in the illness trajectory which changes after the day they've seen the doctor that informs some people that they're getting sicker and other people that they're not. And so we're interested now in trying to look at the diary data that people collect and also collecting new data in order to see if we can predict who has an adverse outcome using data after the index consultation, and so that we can direct people using evidence rather than guesswork about who to take. At the moment, we're saying, well, I say you have to give people instructions, wait a few days, and it's not just a day. For sore throat, you're asking people to wait 4 or 5 days. For an acute cough illness, they're not going to be better for another 2 weeks. So I don't say, well, wait a few days, because I know they won't be better in a few days. I'm saying wait, 6 to 10 days before you take your antibiotic. But that's based on on guesswork. And I say take the antibiotics if you're feeling really bad or you develop breathlessness or fever. But I'm just assuming that those are sensible things to say. They're not based on good evidence. So we need to collect the evidence to direct the right people to take the antibiotics.
Any more questions? Maybe to the other lecturers? Okay, Joachim.
I still wonder a little bit about the use of the point-of-care tests during the consultation. And as it was just pointed out in Germany, we have the situation that, especially on Monday morning, many patients come to the practice and they want to have a sick leave certificate. So patients, there's a group of patients who either want to have a sick leave certificate or an antibiotic. I would say, and maybe the antibiotic for some patients is also some kind of a proof that they are really sick. And so, what do we know about this situation, and how can point-of-care testing help the GP to get out of this trap, the Monday morning trap, I would call it? Maybe one of you can comment on that.
So, we don't have exactly the same Monday morning problem that you have here. Yeah, we're all playing golf on Monday. That's right. I think there has been some data that use of CRP is the best example, can reduce the likelihood that a patient will demand an antibiotic or will improve their satisfaction. One of the things that's different in the U.S. is a portion, in many cases and in many health systems, a portion of how much we get paid is tied to patient satisfaction. And so physicians are driven by that, and so they want happy patients, and sometimes they think happy patients are the ones that get an antibiotic. Unfortunately, and it's embarrassing to admit that, but that's, I think, the case to some extent. But if we separate that out, I do think that a CRP test in that situation has been shown to reduce the dissatisfaction with not getting an antibiotic. There might be some cause for that. I think the group A, C, and G thing is really interesting, and I think we really need a trial on that.
I'm just going to offer one or two reflections. So, the whole of history
is perpetuating our use of antibiotics. These are nothing short of miracle drugs. And as they became more widely used, people felt great that they were able to benefit from them. You know, the doctors like prescribing them because we're the administrators of the miraculous medicines, and the patients like taking them because they're recipients of them. And of course it validates their illness. They can go home and say to their family or their employer, you know, the doctor really thought I was ill. It's easy to get there. It's much harder to get back from there. And I think that's going to take a concerted effort from everybody. You know that slide I had with the iceberg that's going to dissolve? It's going to take public health campaigning to say to people, look, you know, most of us, most of the time, are not going to benefit from these antibiotics. And even worse, they're doing harm. They're causing harm to our elderly. And we're going to end up in a situation where we have infections that are no longer treatable. And, you know, maybe part of the answer is legislation. Maybe it's time, so in the UK, the law is on our side, so we can say to our patients who, even when they get very demanding and they say to us, look, my employer, they're going to sack me if I don't get a sick note. We can say to them, the law is very clear, I'm not allowed to give you a sick note for the first week of your illness. You have to self-sign. So, you know, there will be some legislative. One of the arrows on that iceberg may be legislative for you as well. I think the comment about a public health campaign is a really good one. We did a study where we asked a random sample of patients in the state of Georgia how long they thought. We gave them a bronchitis, a chest cold scenario, with or without fever, with or without green or phlegm or yellow phlegm. And we asked them how long they thought it would last from beginning till end, and the average was about 7 days. They think it lasts a week. Yet if you look at the placebo arm in clinical trials, like many of the trials that Michael and his group have been involved in, it's about 18 days. And so that mismatch between patient belief, patient expectation, and reality drives a lot of the antibiotic use. And I think if I had a bumper sticker, I'd say 2 weeks for a cough. And then maybe that would help get the message out. Or even free.
So just on that public expectation issue, I mean, I don't know if Michael knows, has it been changing? Because on the issue of patient expectation, whether it's been changing. In the UK, I would have said when I started in the mid-80s as a GP, most patients expected most antibiotics a lot of the time. In fact, the only time I've been assaulted by a patient was when I refused to give him an antibiotic for a sore throat. Whereas now I don't have that most of them are expected, as you say, to be told, we don't usually bother with antibiotics for this now. What's different about your problem?
Yeah, I think there is evidence that that beliefs are changing. It's slow. There's a survey which is done periodically every 3 to 5 years of patient beliefs, and it does show some change in that. But my personal experience as a practicing GP is it's quite different now that people are expecting to have a discussion about whether antibiotics are needed or not, and that the more you can do to reassure people, and I think some of the effect of the near-patient test is not about the added clinical benefit, the added diagnostic precision, because we saw the CRP, it's actually it is more precise but small, but actually what it does is to change the dynamic. It's a number. You can say, I have confidence, you can have confidence, you don't need an antibiotic. So I think that all of these things are helping the clinician in their non-prescribing.
Maybe one last comment about patients' attitudes towards antibiotics. There was a campaign, a public campaign in the UK, I think a few years ago, directed towards patients not to ask the doctor about antibiotics for respiratory infections. And 1 year later, the same patients, this cohort, was asked, do you remember there was a campaign? And I think 18% remembered that there was a campaign. So they kept asking the doctors for antibiotics forth and forth. But is there any more question? Yes, one, please.
I just wanted to thank you for the fever pain score and just for our German colleagues. Wenn man das googelt, Fever Pain Score, kommt man auf diese nicht ganz einfache Webseite. Und selbst beim Empfang hier drin, man kann binnen 20 Sekunden das ausfüllen und kann mit einer Tooltip-Funktion sofort den wissenschaftlichen Hintergrund bekommen, sodass zum Umsetzen braucht man wirklich nur einen Internetzugang und es geht. I just said that it's very easy to access your website if you're just putting fever pain score in Google, and then it just takes a few seconds to end up with the result and the scientific background. Thank you.
So, I don't see any hands. Thank you very much for your lively discussions. And before you go into the coffee break, please give a warm welcome to our foreign guests. Thank you very much.